Good afternoon, everyone, and thank you for being here. It's truly a pleasure to be speaking to a group of supervisors because I firmly believe that our role, I'm a psychiatrist, a clinician, and not an academic researcher, and a consultant, EMDR consultant. Our role is one of the most influential and powerful in our EMDR community. Today, I'd like to walk you through some recent and exciting developments in EMDR research. Don't worry, I'm not going to talk so long about EMDR and PTSD. We all know, I hope, that EMDR is effective for PTSD. There are countless studies, meta-analyses, and clinical guidelines supporting that. So instead, with that in mind, I want to take you on a short journey through the expanding frontiers of EMDR therapy nowadays, the areas that are still emerging, sometimes controversial, often creative, and absolutely relevant for our clinical practice as supervisors too. Yeah. Why? There is a question, why research matters to us as supervisors? Because, of course, as supervisors, we are not only teaching protocols. Of course, it's part of our task, but we are shaping mindsets. We influence, in fact, our supervisors think about clinical decision-making, client complexity, and whether or not EMDR is allowed in a particular clinical context. So this is a very important issue because what we believe influences what we allow with our supervising, and what we allow becomes what is practiced. So where is EMDR going? How vibrant is the research field? In which countries is it growing the most? And how can we as supervisors stay connected to this evolution? The good news is that EMDR is absolutely alive and thriving. We are seeing a rapid increase in publications from countries like the Netherlands, Germany, Spain, Italy, Turkey, the UK, often with collaboration with universities, hospitals, and frequently supported by EMDR Europe, thanks to EMDR Europe. As co-chair of the EMDR Europe Research Committee, with Michael Hase as chair, thank you, Michael, we have the privilege of reviewing many of these studies. Every year we evaluate more than 60 papers for the Francine Shapiro Award, and the level of sophistication, clinical relevance is truly remarkable. So, I want to remind all of us that as supervisors, we are bridges between research and clinical practice. As supervisors, we act as vital bridges between cutting-edge research and everyday clinical practice, ensuring that the new findings are effectively integrated into the therapeutic approaches. We are the bridge between research and practice, I've said. We don't just interpret the evidence, we help the supervisor to apply it. And this matters even more as the EMDR is being used in population, as we'll see, where it wasn't previously considered. This bridge function becomes our responsibility, not only a choice. We have in fact the privilege and the responsibility of guiding the next generation of practitioners. So it's important to stay connected to these evolutions in EMDR research. Yet, EMDR still receives skepticism. For example, many of us know that the APA, the Association on American Psychological Association, recently gave EMDR a lower efficacy rating in their PTSD guidelines. That was a wake-up call for many of us. Unfortunately, the new guidelines of APA for PTSD have been released, and we discovered that EMDR has been assigned a 2-level rate after trauma-focused CBT, cognitive therapy, and prolonged exposure. Probably all of us can expect that our supervisor will ask us why, what happened, and so we must be ready and well prepared. That's why I asked to the organizers to share with you, uploaded on the platform, I hope it was done, the excellent work led by Derek Farrell, thank you Derek, and colleagues, as an answer to this. The APA guidelines, in fact, took into account all the studies and not the most recent robust evidence, which is why we need to be prepared to address these concerns and advocate for the latest findings. It's crucial for us to understand and communicate that the evaluation didn't fully reflect the latest and most robust evidence supporting EMDR. We must be ready to clarify this to our supervisors and continue advocating for a fair representation of EMDR in clinical guidelines. I told you that PTSD is an example of as a robust evidence. Just a quick reminder, we do have solid evidence for this. For example, this is a paper published, the authors are Susie Mathisen, Ada Young, Browers, etc. Thank you to the group of researchers, because in this research they conducted a major randomized trial confirming EMDR's effectiveness compared to other trauma therapies. And fortunately, the US Department of Veteran Affairs still includes EMDR in its guidelines. But we are not going to stay in that territory today. Let's step beyond. Research, a European perspective, from a European perspective, and as a European perspective, because the EMDR research landscape is expanding and Europe is leading the way. We have national grants, European level grants, cross-country collaborations in many research. We remember the DEPEND, for example, pilot study, and more publications in published in peer-reviewed journals, like Frontiers in Psychology, for example, or in the Journal of EMDR Practice and Research. And what are we seeing in research? I asked to share on the platform, like the previous one, and also this paper. It's the editorial that Michael Hase and I wrote for Frontiers, and it's a special topic, the volume 3, totally dedicated to EMDR. Why do I permit to suggest this? Because in the editorial we comment the 12 published papers and try above all to identify the general trend in EMDR research. So I think that it's worthwhile if you can go on the website of Frontiers and have a look to the 12 published articles. But on the other hand, the question is, what are we seeing in our clinics, in our clinical practice? More complexity, sure. Cases of complex PTSD, dissociation, neurodivergence, personality disorders, comorbidity, gender issues, and new relational family problems, addiction. And also our supervisors are reporting us that it's hard to find a clear map for this kind of cases. That's why there is a need for a living dialogue between research, supervision, and clinic. But let's begin to look at the new frontiers. Let's begin, of course, with psychosis. This used to be considered a no-go zone for EMDR and trauma therapy, but research and EMDR research is telling us otherwise. We now have several studies, not one, not a few, but several, for example, I included here the important study by Varese and colleagues, showing that EMDR can reduce trauma-related psychotic symptoms, distress from delusional beliefs, voices, and even prevent progression toward a higher risk mental state. So, what does it mean for us? It means that we need to guide our therapists in approaching these cases with both curiosity, openness, and caution, and careful. It's not about diving in, it's about careful formulation, preparation, and attunement. Usually, all of us, we know that in supervision, these cases often bring up a lot of anxiety and doubts from the therapist. Is this safe? Am I making things worse? Is there a risk of a psychotic acute relapse, for example? That's why supervision is so important. We have to help clinicians and the therapists to tolerate uncertainty, recognize early signs of destabilization, and support a more grounded, compassionate approach, because we are supported by the research. Another field, of course, we cannot forget it, is EMDR and complex PTSD, dissociation. These are patients with severe trauma histories, we know, often abuse, maltreatment, neglect, disorganized attachments. Well, recent studies, for example, Wigard, Morero-Zafra, Van Vliet and Archer, etc., confirm that EMDR is effective also in these cases, of course, only when used within a phased approach, the approach suggested by the International Society for the Study of Trauma and Dissociation. What does it mean, again, for us? That as the supervisors, we must support clinicians in passing the work with this kind of cases. Stabilization, very often long stabilization, relational safety, flexibility become crucial. EMDR and personality disorders, so common in our daily practice. New evidence, for example, this very relevant study by Meyer and Young and his group suggested that EMDR can support emotional regulation, reduce self-harm behaviors, and promote identity integration, when used, of course, carefully with proper containment. So we can receive from the research a lot of practical suggestions, practical tips for our practice. EMDR addiction, welcome Turkey. This is an important Turkish paper. As you can see, I have chosen to put in the slides only the papers published in 2024 or 2025, not older. So only to show you how massive is the research in the field. This Turkish paper shows the help of EMDR in processing the role of memory in addiction, and the results are also a replication of an older Hazard's paper. So EMDR can be used to target also the craving and the addiction memory. And 5 minutes, yeah. So this is, I think, a very amazing, astonishing for in some ways, EMDR in intellectual disability and dementia. Probably a few years ago, nobody could imagine this. EMDR can be adapted for people with intellectual disabilities, using, of course, simplified language, concrete tools, extended preparation phases. Early evidence shows that EMDR can reduce behavioral symptoms even in early stage dementia. So a field, of course, where we must proceed with caution. EMDR can be used also in the field of autistic adults and ADHD. Adult ADHD, people with ADHD are full of stressful events, and their past failures, reprimands are received by teachers, by parents, and so EMDR can be absolutely helpful. So there is a new field, the EMDR and the neuropsychiatry, exploring the overlapping conditions between neurological and psychiatric pathologies, opening really new interdisciplinary frontiers. Of course, adaptations include slower pacing, validation of sensory experiences, and a simplified target selection. What happens now? Surely we are moving toward an emphasis of how EMDR is deeply a relational approach. This is a paper published in Frontiers by Haze, Solomon and Haze, and I think it's important to identify the new trend of EMDR. The relational term in supervision, Mark Dworkin's relational imperative, Liotti's motivational systems beyond attachment, highlight supervision also as co-regulation and shared meaning making. So I think that the new trend is to move toward studies of process, therapeutic process, beyond the studies of efficacy. Efficacy is, of course, fundamental, but now we have to understand better the psychological mechanism, relational mechanism of functioning EMDR. Not only, of course, the biological mechanism We are masters in this field, I can say, EMDR. And of course, the research in this field goes ahead formulating hypotheses about the mechanism of functioning from a neurophysiological or neurobiological EMDR, especially about working memory, dual attention research, and of course understanding mechanism empowers the therapist. I go to the final words and those. Of course, the hope is to remain passionate, connected, and curious. Let's support our supervisors in becoming, of course, confident, competent, but also research informed. For example, I think that in the next days I permit to share with you some hypotheses. Perhaps it would be helpful to give tools to the supervisors. Help, for example, to distinguish between absence of evidence, we still don't know if it works in the field, and evidence of absent effect. It's a fundamental distinction. Or how to read and evaluate a meta-analysis, a clinical sample in a research, or how to use our single cases to promote research. So, surely it's not necessary to be a researcher, to think as a researcher. My final tips could be, for example, please read at least one research article per month. Share it on a WhatsApp group with your supervisor. Share the insight during the supervision. Promote the importance of intervision, peer supervision, and build a clinical culture of inquiry, stimulating curiosity. Because as Francine Shapiro wrote, the best research always begins with a good clinical question. So we have to help our supervisor to formulate the good clinical questions, because this is very relevant to stimulate future research and the research close to the clinic. Thank you for your attention.
Thank you very much, Antonio. Thank you for the idea of the supervisors being the bridge between the research and the supervisees. And we just want to give you a little thank you for being here today.